Scenario: 3 weeks post-concussion, a child comes into your office complaining of a lingering headache. She is still unable to participate in normal activities.
Headaches sometimes do carry on, or other symptoms as well. Some of the more common lingering symptoms are often concentration, attention, or sleep difficulties. I think the pediatricians can usually reassure the families by explaining that concussion is not something that resolves overnight. It takes days and even sometimes weeks, but generally we're looking for improvement over time. And so if the examinations are non-focal, then that's when they would remain with the primary care physicians. At that point, it's probably appropriate to have them referred to the neurologist and to see this patient with this lingering headache. Either the primary doctor could refer for neuroimaging of some sort, either as MRI of the brain or a CT, in the interval before actually making the consultation. Or if they haven't had those studies and they come and they're still having those symptoms, then probably would be appropriate to go ahead and do that kind of an imaging analysis at that point in time. When the concussion program was developed, it was actually designed so that our colleagues in primary pediatrics would be able to use our information and handle the patients in their office. The vast majority of the patients will get better as anticipated, and as long as they do and you follow the guidelines, then many of them don't have to come to a specialist's attention. So for the majority of them, they're okay being handled by the primary care doctor, the pediatricians and the family physicians. When the neurologist is needed, or somebody like the neurosurgeon or sports medicine doctor, is more often those patients who have lingering problems, things that carry on over time. If a primary care physician sees a patient who has any kind of focal abnormalities or even suspected focal abnormalities, they should get a referral immediately. Certainly Tylenol is fair game. I mean, that's according to label directions, I think that's good in the usual patient. But the question of the ibuprofen, the common nonsteroidal use of analgesia, I think there's differing opinions. If the child has had any bleeding complications, usually they won't be in their pediatrician's office to begin with, so it becomes more of a non-issue. But if there is any concerns, that would be the situation where you wouldn't want to use a nonsteroidal drug like ibuprofen, but in the majority of cases it should be okay too. The key is balancing the analgesia against other symptoms of, particularly in the most significant one be sedation. You don't want to sedate the child to the point that your examination is unreliable.